I think so, raising many problems are raising with the services, not only medical, but also ethical issue and also legal issue. Who will benefit? Who will have benefit and risk in the cross-border reproductive care? The patients, offsprings, donors, surrogates, providers, and also communities. Why we against to the cross-border reproductive care? Many ethical and practice concern. Number one, about patient safety and quality control. Because the standard is quite vary, variable standard between country, original country, and then to the host country. It's not the same. The risk of exploitations, especially for the donors and surrogates in the low middle income countries. Compton mentioned already. And then there's a barrier in the language and cultural sometimes make a lacking of informed consent, legal uncertainty, and a very important thing post-treatment care issue because limited follow-up from the country that did cross-border reproductive care, and also liability problems. The other ethical consideration also for departure country physicians. Actually, as the physicians in the departure country, they have duty to inform patients about the opportunities, about risk, benefit, should be explained very clearly to the patients. And then resume care of the patients and also the ethical consideration for destination country physicians. They should provide, of course, high quality medical care, but not also acting as patients' legal advisor. And we know the reason doing CRBC not only because of economic factors, non-economic factors, legality, accessibility, quality. If you look in the US, many was like this coming from Canada because of legal restriction in home countries. So in the cross-border reproductive care, we offering indirectly practice against the law. Indirectly. And then we can see as well this consideration regarding cross-border reproductive care, the patient's country of origin, and also the host country. Again, this one for economical issue.
Itu acaranya pagi ya.
Patient often spend significant money abroad. Even Compton mentioned it's cheaper in Thailand, but they spend more money for tourism, for shopping. That should be actually the patient spend their money to their host country to establish the local society, local facilities. And then if multiple pregnancy and ovarian hyperstimulation syndrome happens when they went back to the country, of course, increasing the cost. And Compton didn't know the patient suffering from IVF in Indonesia. The patient having multiple pregnancy and then the baby was taken care in ICU in Indonesia. They spent more money. Insurance may refuse also coverage, both abroad and at home. And then again, it's a surrogacy, may facing citizen issue, and also sometimes by unresolved legal, financial, ethical dispute, and still lack of clear international coordination.
Ada undangan yang pakai nama?
Compton actually mentioned in his lecture.
Ada undangan yang pakai nama nggak?
This is the host country. Commercialization crisis, ethical concerns, risking also exploitations, and then the host country, of course, that should taking care of ensure infection control, proper vitrification, cryopreservation control, and then patients follow up. How would embryo feeding? Many patients they keep the embryos frozen in the destination country. And how many embryos is put because the patient doesn't want to extend the frozen in the destination country. This is an ethical issue. And then we can see also, managing stored embryo and patient follow-up is very important. Language variants, sometimes increasing patient misunderstanding. And then surrogacy, there's a lot of problems. And surrogacy, I think many countries now, prohibit surrogacy. I'm to mention as well in India and also in Thailand. This is many multi-layered complication of surrogacy. Emotional bonding between fetus and surrogate mothers. Who is biological mothers actually in surrogacy? And then risk of exploitation, financial incentive, unequal social status. And this is also the problem with surrogacy. Health risk in the gestational carrier because of the patients coming about to have the RBC, they may be older, also the risk to have the hypertension in pregnancy increasing after IVF. Then the need of screening is very important. Sometimes because of limited economical problems or compromise screening or for ethical standard in surrogacy program. Parental dispute, who is the legal mother? And then legal recognition, I think agreements, surrogacy agreements differs globally. This is a very important issue. And the next about right to know one's genetic origins and how is relationship with cross-border medically assisted reproduction. Because sometimes, especially in the individuals do not conceive, to know their genetic origins. If the loss of identity, the baby loss of identity, they didn't know who is the genetic origins in the donation is conceived mothers. The baby doesn't know, and then genetic history, lack of genetic history, also may cause poor health decisions. If the baby sometimes they get sick, they didn't know what is the history of the donor before. I think this is the problems in the donations. And then imagine technology like mitochondrial replacement and gene editing. There is a new identity and disclosure function. New identity that the baby doesn't know. And then anonymous donor surrogacy may face lasting identity, legal, emotional challenge. And then state and clinic must ensure long-term record keeping and access to information. So that's why we come to the reproductive care. Number one, is raising critical question, maybe tomorrow is a sessions, the growing commercialization of reproductive health care ultimately serve to the investor or to the patients. Become a business and highlight the ethical, social, practical complexities. And then gestational surrogacy, of course, raising complex problems, legal diversity, major barrier recognizing parentage and nationality for the children, and then higher maternal risk because of the patient's conditions, and then largely unregulated, and the genetic origins must be protected through transparent, ethical, and child-centered reproductive policies. So we still in debate. So not only medical, ethical, and legal issue. If you look across the total babies delivered, you can see here total IVF pregnancy. Maternal age is slightly higher. 40 to 37 years old, and then maternal outcome, hypertensive disorder was significantly more common in CIBC pregnancies, almost double. Postpartum hemorrhage, triple. Multiple gestations, double in CIBC groups. So that's why the problems it happened in the original country. Because of patients seeking CIBC was older and faces higher risk of hypertensive disorder, so advanced maternal age, multiple gestation, and different clinical protocols abroad. So I think this is increased maternal risk abroad, CIBC pregnancies. And the last, it's very important, the role of professional facilitators in CIBCs. Especially the facilitator agent linking patients, donors, surrogate, and clinics. The field is largely unregulated, and many facilitators are former patients or former donors, using their own personal experiences rather than professional standards. So this is the problem. And power imbalance. Facilitators often control clinic selection, communication, and contract. Conflict of interest. Some acting simultaneously as lawyers, clinical partners, and receives hidden commission. This is ethical issue. Hidden commissions. The doctors in the country audience acting as a brokers. And we cannot avoid. This is a fact. And then potential exploitations. There's a weak protection for the donors and surrogates. And clients may be misled or abandoned by fake or untrained agencies, emotional framing, current ethic, and few adopt voluntary codes. Enforcement remains minimal. The cross-border reproductive care raising a lot of problems, not only in medical, ethical, and also legal issues. So that's why say no to cross-border IVF. Thank you very much.